today I will actually indeed switch gears. So I'm talking about neurons. I'm neither a peripheralist nor a centralist. I'm kind of a globalist. Um, I will be talking about itch. So it's very different to what we heard about human sensory neurons and pain and chronic pain. And I am talking about the same systems, but in relation to chronic itch. So this is the talk outline. And then I will give a little bit of a background on itch. I love this quote. This is a quote from poet Ogden Nash that puts two words, namely scratch and itch, in such a positive connotation, whereas it's like terrifying for patients that suffer from chronic itch. So itch was defined more than 350 years ago as an unpleasant sensation that causes the urge to scratch by the German physician Samuel Haffenreffer. So easy to say. I'm glad I have German heritage, so I can kind of pronounce it. In general, it was considered itch in general as a somatosensory modality, as a submodality of pain, kind of like a mild form of pain. Until recently, a lot of discoveries have really advanced the understanding that itch is a very distinct and very specific somatosensory modality that is very unique to the skin, which makes it very, very interesting. So in the clinic, there is acute itch and chronic itch. Acute itch is the itch that you experience when a toxin or an irritant enters the skin. It's very short. It can last 2 weeks. So if you look at those pictures, you can see that one is urticaria, which is characterized by these hives, and then one is the mosquito bite. So there are different causes for acute itch. Again, irritants, toxins, an allergic reaction, and urticaria, which is another form. It can end up in a chronic version, but it's an allergic reaction of the skin in hives and insect bites. Whereas chronic itch is a persistent sensation lasting longer than 6 weeks. But in fact, in the clinic, patients suffering from chronic itch, they have it for months, up to years. And it's really, really devastating. And it's a huge burden in their life, similar to what has been mentioned for chronic pain. You can really, really talk to chronic itch patients, and they will tell you that they have such a horrible life. They don't sleep, they can't focus, they have troubles in doing all day regular activities because they are consistently occupied by this sensation of itch. It's really, really devastating. There are different causes for chronic itch, dermatological causes, and we will talk about this a little bit in more detail during my talk. Systemic, such as kidney failure, liver cirrhosis, which you might know, and then HIV patients. It's actually interesting that in the chronic itch clinic, patients who have HIV do also experience chronic itch. It can be treated with a lot of like this chronic pain and more centrally active targets that are out there, but patients do come with complaints of chronic itch. Then neuropathic itch, so itch that is caused by post-herpetic invasion or infection, then injuries to the spinal cord, multiple sclerosis patients suffer from itch, and then we have psychogenic itch. So there is this itch that is actually more descendingly processed as itch and ends up in patients of obsessive compulsive disorders and then in cases of substance abuse. So if you look at these pictures, so this is the classical dermatological itch for atopic dermatitis, which can start in early childhood. This is a cholestatic itch for during pregnancy, which is also quite common. And then here, this patient scratched her scalp open, and she did not even feel the pain. And all she was complaining was the chronic itch she was feeling. So it is really, really huge in terms of impact on quality of life. So again, sleep deprivation, a loss of daytime activities, and then poor school performance in children who suffer also from chronic itch. And the childhood eczema, as it was called, atopic dermatitis years ago, is actually a disease that has more and more incidences, and it's also meanwhile appreciated that it's an adult disease. So let's have a look how itch is being sense. So generally, the forefront of itch sensation happens in the skin. And we will talk also and understand why the skin is the only organ that actually senses itch and pain. So if you go back to all the different talks we really enjoyed, the other organs can sense pain. There is some itch in the throat, but if you consider it, the biggest barrier to the outside world is the biggest organ that can sense itch and pain. So that's actually the reason why I was interested in learning more about the differences and similarities in itch. So I was trained, by the way, in Dr. Alan Basbaum's lab in neuroscience. And for a big portion of my time during my training, I was the itch girl in the pain lab. So I was always called out, oh, you want to talk to the itch girl. So that was me. So I'm still doing what I'm doing, but I transitioned into companies where I'm helping to advance the understanding and how we can really move assets that are relevant for the treatment of dermatological conditions to the clinic, and then ideally to treat patients in real life. So um, classically, itch is mediated through primary sensory efferents, which are innervating the skin, as you can see here. And we have two major pathways. One is the histaminergic itch pathway, and the other one is the non-histaminergic itch pathway. As the name tells, histaminergic itch is mediated by histamine. So it's only one poritogen. Those are the agents that cause pruritus, which is a Latin name for itch, is histamine. Whereas all the other itch-inducing agents, namely poritogens, are mediated or conveyed by the non-histaminergic pathway. And then it will be coded and relate to this spinal cord, and then actually in the brain processed as itch or coded as itch. We know in itch, similar to other organs where you have pain, there is a very tight interaction between immune cells, residential epithelial cells or endothelial cells, and the sensory neurons, which are key factors. So itch is carried by unmyelinated C fibers, which are a kind of like a compartment or a subpopulation of the nociceptors. These cutaneous neurons innervate the skin, as seen here, and they really are equipped with different receptors to sense the poritogens that can enter the skin or are being released from here. And they have all these receptors that are, so to say, the itch-specific receptors on these sensory neurons expressed. And again, they are a subset of pain nociceptors, transmitting neurons, and they are called poritoceptors. So generally, similar to pain and chronic pain, there is this complex inhibitory and excitatory interplay on different levels. So the sensitizations that you also know or heard of that happens in chronic pain, we have the same mechanism occurring in chronic itch. And you also have a sensitization process that happens in the central nervous system. And there are also changes in the brain region that are highly activated in chronic itch patients, similar to chronic pain patients. So I actually realized after Dr. Price talk that this is absolutely wrong. So I'm going to, I have to delabel this, and instead of saying it's non-peptidergic, I will label it as a neuronal population. So this shows just like that there are different neuron populations that were identified in mice. And as we just learned a few hours ago with Dr. Price talks, that this is not necessarily standing, but conceptually probably somewhat in the right region. That's why translational work is really important. So there are different receptors that are specific to the neuronal populations that are itch-specific. And then I want to point out that there are cytokine receptors. So receptors that are tuned to react to immune cell or non-neuronal cell released cytokines on those itch-specific receptors and also on pain receptors. But this is really important for the flow of my talk, but then also to show that there is really a direct neuroimmune communication in chronic itch that is relevant for a variety of different diseases. And this is definitely the case in atopic dermatitis and other like dermatological skin disorders where the phenomena of itch and pain can occur. Oh, maybe before I move on, I just wanted to point out, this is also fascinating that we have contagious itch. So usually when I talk about itch, at some point I see either somebody scratching, I just saw it, and then this is so funny. It's especially when you're at an academic conference, and then when I was presenting all the different teratogenic pictures, which I kind of like shrinked here. But it's very fascinating that one starts scratching and then it's so contagious. Yeah. So this is similar to yawning, considered as contagious itch. And there are mirror neurons in your brain that actually signals this. So which is very interesting. And then here, mechanical itch is a different subpopulation. Again, I have to point out this sketch that I put together is based on findings from mice. I'm pretty sure this will be revolutionized soon, hopefully. Okay, so again, what is important is that we have different cytokine receptors on this neuron population. So one of the classical diseases that is defined by chronic itch as a cardinal feature is atopic dermatitis. It's a very, very chronic, inflammatory, relapsing skin disease that can start as early as like in 2 to 3 months old children and can persist throughout your whole adulthood and life. As you can see here, it's characterized by erythema, by this lichenification due to scratching and skin barrier disruption. Here, like also erythema in a younger patient. And then here's the lesions and the lichenifications that can occur. And then here's this. So the skin, it can be affected in moderate to severe atopic dermatitis patients up to 80% of their body surface. So it's quite impactful to have your body like consistently itching. So if you I think there's a video going around of a chronic itch patient that was filmed overnight in the clinic, and the patient didn't sleep. So that's what these patients experience. So it's a quite prevalent disease that is up to 13% in children and 7% in adults in developed countries. And it causes massive suffering. And again, one of the cardinal features of this disease is chronic itch. So patients who have atopic dermatitis will suffer at some point from chronic itch that can be prevalent up to 100% in atopic dermatitis patients. So what is interesting is that when Dr. Niesenbaum was talking about the table, and I think like he had maybe 8 drugs, FDA-approved drugs in the table for chronic pain, I want to point out, despite the fact that chronic itch has a high incidence and there are a lot of different diseases that show chronic itch as a symptom, there is not one single FDA-approved drug out there. So which is huge if you understand that the burden of life can be similar for chronic patients suffering like chronic pain patients. So I think that's something that tells us this has to advance a little bit more. Like in atopic dermatitis, what we have is that there is a epithelial barrier disruption that allows the entrance of irritants, toxins, and then allergic molecules. And then as soon as these enter the epidermis and the dermis, there are innate lymphoid cells that are activated, and they release power molecules that are called alarmins. Those alarmins then subsequently induce the activation of immune cells, the Th2 cells that also Dr. Price was mentioning, the CD4, CD8, Th helper immune cell population, which release different cytokines. We have here I13 and I4. These are considered as the predominating type 2 cytokines in atopic dermatitis. They have a lot of functions because the receptors sit on a variety of different cells, and they can activate those cells via the receptor complex. And also the receptor is known to sit on sensory neurons, so the I4 receptor and I13 receptor, which is shared by I4 and I13. And then you have this itch scratch cycle, which is kind of like the huge thing in atopic dermatitis patients. So there is the vicious itch scratch cycle that is definitely goal to be treated in patients suffering from atopic dermatitis. So just to have a closer look on how IL-4 and IL-13 functions, because it's related to the drug that I'm working on, which is eblazakimab. So both signal through the type 2 receptor complex, which is uh, composed of two subunits, the IL-4 receptor and the IL-13 receptor alpha 1. And these two subunits have two heterodimers, and then allergic inflammation will occur. They drive inflammation in a variety of different tissues. Here the focus is atopic dermatitis, hence the skin tissue, but very likely this plays a role in also asthma and other inflammatory allergic skin conditions. They are present in high levels in the skin and in the serum of atopic dermatitis patients. However, it has become evident by previous work that IL-13 seems to be the key cytokine in atopic dermatitis. It's very likely, though, that IL-4 still plays a minor role, maybe like in driving the comorbidities that those patients suffer, such as, for example, allergic rhinitis or asthma. So the molecule I'm working on is eblazakimab. It's a monoclonal antibody in the clinic targeting the IL-13 receptor. It's actually very unique because unlike other molecules, it's really blocking this type 2 receptor signaling, which is relevant for the allergic inflammation. Whereas IL-4 can signal through another receptor complex, which is called the type 1 receptor, which is relevant for immune regulation and has nothing to do with this allergic inflammation process. So, and then additionally, the type 2 receptor can amplify itch signals, which we will be talking in a little bit. And here we wanted to understand how IL-13 R alpha 1 plays a role in contributing to itch, but maybe also to something that was mentioned before, to spontaneous activity in chronic itch patients. And then whether blocking IL-13 R alpha with eblazakimab can lead to improvement in itch. So I've been working as Andrea was mentioning for many, many years. I've been working on this neuroimmune crosstalk in itch and in pain. And I've been working with Paul and Yannick for many, many years. And we have been doing a lot of research. So what we do is actually looking into human sensory neurons, and we try to understand whatever has been published for mouse pruritus, if it's really translated into human pruritus. And we have done a lot of work. We started with just testing the cytokines, how they would eventually lead to direct activation. We did not see any direct activation, so hence we understood that those cytokines do amplify itch in a very different way and mediate itch. So let's have a look at the data. Before I share with you some of the data we have in our teamwork, I want to point out something that I think like it's really relevant again to understand how much of a gap between mouse and humans is out there. So I'm using different pruritogens. This is a very common pruritogen. It's bovine adrenomedulin peptide 822. It works very efficiently across species. So you can inject humans, they will have itch. You can inject mice, they will react with scratching. It activates in humans the MRGPRX1 receptor. These receptors have really, I would say, brought big insight into the itch biology because they have become to prominence by being the itch receptors that are relevant for the non-histaminergic itch. And then in mice, BAM is mediated by MRGPRC11. And then I'm using another peptide that is activating the MRGPRX2. And in the literature, it has been only shown that MRGPRX2 and then the mouse functional homologue is MRGPRB2 is in mast cells. And our data kind of like shows that there is definitely expression in human sensory neurons and that the receptor is active. But if we have a look at the MRGPR family, it shows that there is a big range of members in the mouse genome, and then there are only 4 members in the human genome. And all they have is there's no genetic homology, no protein sequence homology. There's functional homology. So I mean, I don't know if it's probably not very readable, but so the PAMP that activates B2 will also activate X2, and then there's like some other molecules, but I'm focusing on X2 and X1. But the receptors except X2 are all known, the X1, X4, and MRGPRD, to be expressed in sensory neurons. So all we didn't know was that X2 is actually also there. So again, as mentioned before, when we looked at the human neuronal model, so we do pre-stimulate the cytokines, the neurons with cytokines, and then subject them to different puritogens. And as mentioned before, when we only put the cytokines on human sensory neurons and look at live cell calcium imaging, we don't see any responses. So there is definitely nothing. But if we pre-incubate as short as 5 or 20 minutes, we can see an increase in the responses to puritogens. So there is definitely what we called actually neural enhancement of itch signals through those cytokines. We call them the neural amplifiers. And then when we do look at I4 and I13, we do see that both of the cytokines can enhance BAM, which I have to admit now after watching all the talks, I should have put more data and maybe the live cell calcium imaging traces in here. They would have been nice to show the differences of intensity amplification when you pre-stimulate with cytokines, and then how this is actually being reduced with the antibody. So we do see that I4, I13, and IL4 and I13, the combination, it does induce kind of an intensification of the itch signal, and then eblazakimab, our biologics, can reduce these signals, which really helped us to understand that there is a molecular basis for the itch reductions that we observe in the clinical trials that we are running. So currently our molecule is in phase 2b clinical trials, and we have data readout around second half of the year. So stay tuned. Then we did use PAMP, the same approach, and then here you can see the difference actually. What we did see with PAMP is though that I13 pre-stimulation leads to intensification or amplification of the itch signal, whereas IL-4 did not exert any amplifier effect. So that was very interesting because until recently, it was always assumed when IL-4 and IL-13 are present, which doesn't seem to be the case in atopic dermatitis where IL-13 is predominating, it seems that they have redundant roles. Whereas we show here in human sensory neurons, they can exert distinct roles, which is very, very novel in its actually broad scope of research that might come up our way. And then eblazakimab here in gray is able to block this amplification that is driven by IL-13. So now I'm going to talk a little bit about something that is very novel for Th2 cytokines that are relevant in allergic inflammation. We have tested here with Anabios neuronal spontaneous activity, kind of like as a mechanism of hypersensitivity that is observed in atopic dermatitis patients, but then also in a variety of different other skin suffering patient populations, skin disease suffering patient population. So similar to chronic pain, and I think we had a few talks, and I remember that Dr. Price was mentioning that in his chronic neuropathic RNA-seq data, that there is like the spontaneous activity that he showed with this electrophysiological data. There is definitely a hyperactivity of sensory neurons, and we do think that the similar process is occurring in chronic itch, independent of the cause. So you do have, like, you have to imagine, you have consistent inflammation, consistently the release of different like inflammatory mediators, or maybe in this case even neuroinflammatory mediators. Of course the neurons will react, and we know actually from previous work that when you have cytokines and have them, so to say, stimulate on sensory neurons for a longer time, you do have gene regulatory changes. So there is definitely huge impact, even with cytokines, that can happen and lead to spontaneous or hyperactivity in sensory neurons. So we do think that a similar process might be the case for Th2-derived cytokines, but then additionally, it might build the basis of some of the observations that atopic dermatitis patients have. So one of the things is, for example, atopic dermatitis patients or patients with chronic itch, you can actually apply something that is more painful, and they will still tell you that they have itch as a sensation, which is very interesting. And then non-itchy stimuli, such as, for example, just like cotton sweater, that will cause itch in those patients. So there is also another component that it shows that there is a really different hypersensitivity, a hyperactivation of the neurons occurring. And then what we did here is we first looked at, this is also with lifestyle calcium imaging, and you can check on Paul and Yannick for more details on the data and where you can retrieve it. So we tested the inflammatory soup and compared it to vehicle, and we thought like maybe I4 will lead to increase of the inflammatory soup. The inflammatory soup contains bradykinin and prostaglandin. It's kind of like a typical cocktail for pain research, and we thought like maybe we can apply it for itch research. What we saw is that actually I4, if you look at the kind of like the lines here, increases the number of neurons that are spontaneously active when it's on sensory neurons compared to vehicle, but there is no effect on or additional effect on the inflammatory soup effects that you can see here compared to this panel. So there is definitely an effect of Th2 cytokines on spontaneous activity, which is really huge. So when we looked whether eblazakimab would be able to block these effects, we did indeed see that eblazakimab, if you compare what happens here and then to what happens here, that it's really efficiently blocking these spontaneously active neuronal responses when I4 is pre-stimulated. I think this leads me pretty much to the key takeaways. So I really want to emphasize that in the research we are doing, we really have to understand there is a huge mismatch between the findings that have been published and between what we are trying to do to treat patients. And I think it's really important that we try to advance and put our money into finding more translational models. I'm not neglecting preclinical models. I think they are amazing to find targets, but I think to move something into the clinic to treat patients, we really have to find ways how we can help inventing new tools or like optimizing new tools. So like what I showed here is that eblazakimab, which is a biologics in the development for atopic dermatitis for the treatment of moderate to severe patients, is able to block neural responses to BAM 822 that are intensified by I4 and I13. Then additionally, what we saw is that unlike the literature, there is a distinction between the functional role of I4 and I13. And here we see that I13 sensitizes the human dorsal root ganglia to PAMP20, and that MRGPRX2, unlike it's been disclosed in the literature from what has been known in mice, it's actually expressed and functional in human sensory neurons. So it's not only in mast cells. And then Th2 cytokines may have more neuronal enhancer roles than what we assume just in itch. And so eblazakimab was efficient in blocking the BAM, the 822-induced neuronal effects by the cytokines and also by PAMP20. And then I think like what is really exciting is the neural excitability that we have seen with Th2 cytokines, which opens a complete different repertoire of research avenues. And then this is a little bit like the work I would like to continue. I would like to understand a little bit more about like neural excitability, because I think it goes beyond skin diseases. It goes beyond treating chronic itch conditions. And then I would like to understand what IL-13 R alpha blocking else can do. And with this, I'm at my acknowledgement slides. I would really want to thank Paul and Yannick for sticking around with me. I call Paul my partner in crime for many, many years, normally secretly in my head, but it's been a really good journey, so thank you. And I would like to thank my current boss, who's the CEO at Aslan Pharmaceuticals, for really, really being positive and helping me to advance the research I'm doing. So, and then most of the sketches have been done by a friend of mine. She works at, that's her consulting creative studio consulting firm. And then I have a medical group I'm working with, the Prescott Medical Group Communication. So I love the sketch. So this is actually by Dr. Ethan Lerner from Harvard, who came up with this, and it's in one of the reviews we have. So thank you for your attention. And thank you for the opportunity.
Thank you, Ferda. We have time for, well, say 2 questions.
So what about the sort of spatial localization, innervation density in the skin. So this goes back to something I did in graduate school when we were trying to make a C-fiber selective pain stimulus. We put a platinum wire on the crease of
Yeah.
your finger and
Yeah.
passed DC current, and it produced itch. You turn up the current, worse itch. It would never become heat, never become pain, just itch.
Yeah.
So I'm not. So what's known about sort of where on the body? What's the innervation density
Yeah,
of
I
itch
think
receptors?
that's a very good question. I think that's like feeding into a lot of research that Martin Schmelz is still doing, and Hermann Handwerker has been advancing. So I think like there is like this which where pain can mask itch, and it has to do with the neuron populations that is being activated, but then also on the region and the pattern of activation on the skin. So I don't honestly, I don't have a clear answer to that, but I think like it has to do with like if it's more punctuated or if it's more overlapping, and it might be that with the way you're activating or stimulating the primary afferents innervating the skin is kind of like the population you're finding and the receptors you're activating. But I don't have a better answer. I don't know if anyone from the peripheralists and centralists can help out here. But
Okay.
that's my answer. Yeah.
Thank you.
Thanks. Excellent talk. First, an
Thank you.
open-ended question. I was wondering if you care to comment on the potential role of the microbiome and how that might be harvested pre or probiotically for therapeutic benefit.
Oh, that's a really good question. So I don't know how the interplay between the microbiome and the neurons is, but very likely that there is something, because we know that like for example, like bacterial Staphylococcus aureus is directly activating neurons. So the microbiome in atopic dermatitis patients or in many, many other skin disorders does play a role. But I think the microbiome is so, I don't know how to say it, but very fluid. And very heterogeneous. I do think that there is definitely a component that plays in. In atopic dermatitis patients, there is definitely, it's a complex disease where there's genetic factors that play in, but it's not always the case. So not everyone, there are certain mutations that are being assigned to the disease, but it's not always that atopic dermatitis patients have that mutation. And then there is immune predisposition. And yeah, so I think the microbiome plays in. I don't know if it's more like secondary to the restoration of the skin or to the deterioration of the skin where it is affected.
Thank you. And second, I was wondering how you imagine eblasakimab would differentiate from dupilumab, which
Yeah.
is a IL-13, IL-4 biologic.
Yeah, that's a very good question. So that's my task actually at Aslan Pharmaceuticals, and I love it. It's really very good and very challenging. So what we think is so that by targeting specifically the type 2 receptor by only affecting the IL-13 receptor alpha component, and then not impairing the type 1 receptor that is more involved for IL-4 signaling. So the IL-4 can signal, as I mentioned briefly, and I might have rushed a little bit through this, but IL-4 can signal through two different receptors, whereas IL-13 signals only through the IL-13 receptor alpha binding. And when you spare, so to say, the type 1 receptor, you might have advantages over not disrupting immune regulatory function and maybe also avoiding some of the side effects that are seen in patients treated with dupilumab, which is the conjunctivitis. So, and there might be like some correlation, but stay tuned because that's literally my job at Aslan. Thank you for the question.
That's a very interesting talk. Thank you. In your sensitization experiments, when you saw the inflammatory soup, putting it on there, at least you only showed us the 15 minutes afterwards. You know, in many of the experiments they do that in the pain field, I mean, we didn't look at them until at least 30 minutes later, but sometimes it took 2.5 hours for it to have an effect, even though we washed it off after 5 minutes.
Yeah.
So do you think you might be missing something if only looking at 15 minutes? And do you think there might be a central mechanism like we have in pain
Yeah.
where you're getting widespread itch, after you put the inflammatory soup on one area. Do you think that's could be similar?
Yeah, so I mean, again, this is like all research that is in its infant steps because unlike pain, I mean, itch was really neglected. Until recently, people were assuming it's kind of like a mild form of pain. So this is data I was able to share with you, but it's definitely data that needs more to look in. We did pick in these studies certain time points where we felt comfortable to look into. But definitely, I mean, we could have looked earlier. So we pre-stimulated for 72 hours. We could have looked after 24 hours and possibly would have seen. And we could have looked into later time points where we would have maybe kind of like seen a dynamic of activation pattern. But yeah, very good point. Well, thank you,
Thank you,
everyone.
Ferda.